basically what I was trying to get at is, would you offer an immunotherapy or an IO agent in the second line therapy? So last year we had the CONTACT-03 data, which came out, which looked at the addition of atezolizumab to cabozantinib versus cabozantinib alone. And then this year at ESMO, or more recently, we had the TiNivo-2 study come out, which looked at tivozanib plus nivolumab versus tivozanib alone. With the CONTACT-03 trial, a lot of people were concerned about the difference between using a PD-1 inhibitor versus a PD-L1 inhibitor, since PD-1 inhibitors are more commonly used in frontline therapy. But the study had shown that there was no benefit to adding atezolizumab in the second line setting. And the TiNivo-2 study similarly showed that the addition of nivolumab, which is a PD-1 inhibitor that we do use commonly in these regimens, also did not show a benefit in the second or third line therapy. So what the participants in the panel had discussed was, would you at this point consider adding a checkpoint inhibitor or not? And the consensus was no. So then it was a debate between what subsequent TKI would you use. So we now have data that belzutifan is active in patients with clear cell renal cell carcinoma and subsequent line therapy, so patients who have had one or more treatments. So the question was, would you switch class to something different, a HIF2 alpha inhibitor, versus just switch the TKI to one that the patient had not experienced, had not received before. So we chose cabozantinib, one, because we did not have the data on belzutifan available at the time I was treating the patient, but at the same time, I think it's most people in the room had also stated that they're using belzutifan more in later line therapies and not immediately as second line therapy.